Good morning, everyone. Am I visible? Am I visible? And am I audible or not? So I'm
Yes,
sharing my screen. Okay. We have yet to finish the GIT. So today we will finish the GIT, and from tomorrow we will try to finish the genital to unit tract, and after that we will do the general surgery. Okay. So we will try to finish everything. So shall we start now? So is it visible, right?
yes, ma'am.
ओके तो जीआईटी हो चुका था, ये ट्यूबरक्लोसिस नहीं हुआ था ना लास्ट क्लास में? हेलो हेलो, मैं कुछ पूछ रही हूँ, मीत मैं पूछ रही हूँ कि ये गैस्ट्रो इंटेस्टिनल ट्यूबरक्लोसिस हो चुका था लास्ट क्लास में कि नहीं हुआ था? कुछ याद है आपको?
No, ma'am.
नहीं हुआ था ना? ओके, सो स्टार्ट विथ them. Okay, so because I think we have done the intestinal obstruction, the paralytic ileus. Yeah, volvulus tak we have already done. Okay, now from today we will do the gastrointestinal tuberculosis. Okay, so basically, let me just remove this one. So usually there are two type of tuberculosis. One is your primary and other is one the secondary. Okay, so just write it down. The one is primary and the other is secondary. So primary one is mostly due to the ingestion of the like contaminated food. Okay, so primary one, the main cause for the primary tuberculosis is ingestion of contaminated food containing mycobacterial tuberculosis. Okay, so mycobacterial tuberculosis is basically responsible for the genital gastrointestinal tuberculosis. Sometimes if there is an ingestion of this bacteria from this contaminated food, which resulting into the primary tuberculosis. Secondary means that is from the lungs. So from the lungs, it goes into the stomach while swallowing the sputum. Okay. So arising from the swallowing the sputum from the lungs. So basically there are two types. One is your primary and other is your secondary, or sometimes there is a lymphatic spread also. Okay. So lymphatic spread from the lungs to the gastrointestinal region, especially in the mesenteric lymph nodes. So nowadays primary tuberculosis is less. Okay, but secondary tuberculosis is still there. So whenever there is a secondary tuberculosis, you should ask the patient that in ever history, like in your past history, whether you have suffered from any TB, like lung TB or not. Okay, so because gastrointestinal tuberculosis is primary only after the ingestion of the contaminated food, or most commonly if there is a past history of the lung tuberculosis and now the person is suffer from the GIT tuberculosis, either due to the swallowing of the sputum containing Mycobacterium tuberculosis or due to the lymphatic spread, it enters into the mesenteric group of the lymph nodes of the abdomen. Okay, so now there are three types of intestinal tuberculosis. So one is ulcerative type. If I'm going too fast, let me know in the chat box, because I think if I'm talking too fast. Okay, so one is your ulcerative type, the second one is a hyperplastic type, and the third one is your sclerotic or the fibrotic tuberculosis. Okay, so this is the basically have more chance to develop the adenocarcinoma of the colon. So the third one is your sclerotic or the fibrotic tuberculosis. Okay, fibrotic tuberculosis. The one is your ulcerative, second is your hyperplastic, and the third is your fibrotic tuberculosis. So this is most common is your ulcerative, 60% most common, and 10% is the hyperplastic type, and the 30% is the fibrotic tuberculosis. The most common is ulcerative. So what you will see, there is an ulceration, intestinal ulceration develop in the, especially in the terminal ileum. Okay. So most commonly the ulcerative type, the most common location is in the terminal ileum. So this can be one of the MCQ question. Here the most common symptoms will be the bleeding. There is a fistula and formation of the stricture. Okay, multiple ulcers, especially in the which part of the intestine? The answer will be terminal ileum. Ulcerative is most common. Okay. Now come to the hyperplastic. In the hyperplastic, you will see this, there is a mass and obstructions. Okay, so there is a thickening of the bowel wall in the hyperplastic type, whereas in the sclerotic you will see that like a stricture. Okay, it is associated with the stricture in the intestine, especially in the um, ascending colon, and you will see that napkin ring. Now this in the napkin ring stricture you will see, especially in the fibrotic tuberculosis. Okay, so this is also, that is narrowing of the terminal lumen may occur. So that is Turtling sign or the pure string stenosis or the napkin ring stenosis is usually seen in the fibrotic type of tuberculosis. Okay, so ये तीनों आप याद रखना. What is the three common type? Okay, so here the most common symptoms will be the bleeding. Okay, the most common symptom is bleeding. There is an enlargement of the lymph node. There is a fistula. Perforation is there, but it is rare. Okay, perforation is there, but it is rare. In hyperplastic, there is an obstructions. There is an inflammatory changes, formation of these nodules, node formation of mass. So obstruction is the most common symptoms. Okay. Now, what is the most common symptoms for the intestinal tuberculosis? The clinical feature, the most common symptom is abdominal pain. Okay, so what is the most common symptom? That is the most common symptom is abdominal pain. So this is one of the MCQ. Okay. After that, because TB, all the clinical feature of the TB will be there. For example, there is a rise of temperature, so fever, night sweat, weight loss. Okay. So these are the other common symptoms. So most common symptom is abdominal pain and the other is the diarrhea, followed by the diarrhea. And all the symptoms of the tuberculosis, that is low grade fever, there is a night sweat and the weight loss is always present. So what is the most common complications in hyperplastic type? It is your obstructions. In the ulcerative type, it is the formation of the fistula or the strictures. Okay. And if they ask you what is the most common laboratory diagnosis, you will see in the intestinal tuberculosis, that is most percent in 90% of the cases, there is an increase of ESR. This is your most common abnormality. Okay, so most common abnormality. So this is most common abnormality is a increase of the ESR. Okay, and in the ultrasound you will see this club sandwich appearance. Okay, if you see this is just like a sandwich. Okay, yeah. Okay, like a sandwich appearance. Okay, so this is called a club sandwich appearance, which you will see in the intestinal tuberculosis. So these are all MCQ based. ये पूछा जा सकता है. They can ask you about the Koch ring. Okay, very important. Napkin ring stenosis is seen in which disease in the intestinal tuberculosis. Okay, and if you do with the ascitic fluid, okay, the ascitic fluid, it will show you increase of the protein. Okay, it will show you increase of the high protein and there is an increase of the lymphocytes. तो इतना important नहीं है. Important is this one, club sandwich appearance, napkin ring stenosis, the type of intestinal tuberculosis, and what is the most common type, okay, and the most common clinical feature of the intestinal tuberculosis. Okay, so these are the some of the questions. Now, if they ask you what is the most common site of involvement in GIT tuberculosis, if they ask you what is the most common type, your answer will be terminal ileum and the ileocecal junction. याद रखना, ठीक है? If they ask you what is the most common site for the GIT tuberculosis, your answer will be terminal ileum, okay, and the ileocecal junction. Okay, so yeah, click लो, just give me 1 minute. So is it okay? Shall we move on to the next part? Okay. अभी देखते हैं the about your carcinoid syndrome. Okay. So now come to the another important one about your carcinoid tumor. It is arises from which cell? This can be one of the question. It is arises from the enterochromaffin cell. This type of the cell is present in all over the body. Its other name is Golgi cell, and they secrete serotonin and the other vasoactive substances. पूछा क्या जा सकता है? The distribution of the carcinoid tumor. You will get more commonly in the pathology of the medicine. Okay, so the most common site will be the it should be like BIRACS. The most common site is the bronchus, followed by the intestine. The intestine is your ileum. So this is the mnemonic. याद रखना. This is the mnemonic. BIRACS. B for the bronchus, most common. I for the ileum. Okay. So B for the bronchus, I for the ileum, and R for the rectum, A for the appendix. Okay. A for the appendix, C for the colon, and the S for the stomach. This is the most common site of the carcinoid tumor. Okay, okay. Previous slide about the carcinoid tumor, Dr. Alicia?
Yes,
Or
ma'am.
okay. So this is so, and if they ask you what is the most common foregut location of the carcinoid tumor, if they ask you what is the most common foregut location of the tumor, then your answer will be stomach. Okay. Nahi to most commonly it is seen in the bronchus region. Okay. And wherever the carcinoid tumor is present, the symptoms will depend upon the where the carcinoid tumor is situated. But its most common symptoms will be your flushing, because they are producing some vasoactive substances, so there will be sweating, flushing. These are the common symptoms. For example, if the carcinoid tumor, if it is present in the ileum, it will be the most common symptoms. It will form an obstruction. ठीक है? So इस तरह से, so depend upon where the tumor is located. And the biochemical marker will be 5-hydroxydoloacetic acid in the 24-hour urine. It is the most important testation for the carcinoid tumor. तो ये एक multiple choice एक क्वेश्चन आ सकता है. तो what is the biochemical marker for the carcinoid tumor? And they are the highly specific. Okay, and these are the highly specific. Okay, and other is your increase of the serum chromogranin A. They are also 100% specific. So these two tests are used as a biochemical marker for the carcinoid tumor. Okay. Hmm. Hmm. So let's move to the next part. So this is all about, now come to the next part about the small large intestine. Hmm. So if you see, what you mean by the megacolon or what do you mean by the Hirschsprung diseases? Now, if you see this like diagram, you will see that there is a constriction in the lower part of the rectum. So what happened? It is Hirschsprung diseases, or the other name is in it's a congenital megacolon. Okay, so this other name is a megacolon. Why it is megacolon? See, because of this enlarged colon, its other name is a megacolon. So what happened in this case? So suppose this is our ascending colon, descending colon. Sorry, this is ascending colon, transverse colon, and the descending colon. Okay, so this is the rectum and here. So there are some nerve cell is present here. Okay, which help in the peristaltic movement of the whatever the stool. Okay, so there is a peristaltic movement is happening in the lower part of the rectum. So it contains some nerve cell. It contains, it's basically mesenteric plexus. Now this mesenteric plexus contains some neurons. They contain some nerve cells. They contain some receptors. Okay, synapses. Here in congenital megacolon, this mesenteric plexus is absent. So if this mesenteric plexus is absent, there means there will be no peristaltic movement. Okay, कोई peristaltic movement नहीं होगा. So what happened? Whatever the content which is going up to the descending colon, it cannot passes through the rectum. As a result, because there is no peristaltic movement, as a result, the most common symptoms you will find is especially in like in grown-up children is severe constipation without the fecal soiling. Okay. So basically, what happened? The main condition will be your there is an no mesenteric plexus. So mesenteric plexus is absent, or there is a defective migration of the neural crest in the colonic mucosa. The neural crest is basically a mesenteric plexus. Okay. Or there is an absence of the ganglion cell, because the mesenteric plexus contains everything. So it contains there is a no ganglion cell, there is a no plexus. As a result, there will be a no peristaltic movement. So what are the symptoms you will find in these diseases? Number one, suppose if it is in the neonates. So there will be the first symptoms will be delayed passage of the meconium in the first 24 hours. Okay, so there is a delayed passage of meconium beyond the first 24 hours. Beyond the first 24 hours. Okay. अगर कुछ stool ही pass नहीं होगा, anything is not there. So first symptoms will be that there is a no meconium passed, okay, from that neonate in the first 24 hours. As a result, obviously, there is an abdominal distension. Okay, so this is a very common symptom after that, abdominal distension. So this is in the neonate. Okay, now for example, if the child is grown up for the first few weeks of the life, okay, 2 दिन चला गया, कोई प्रॉब्लम नहीं हुआ, थोड़ा बहुत पास किया, ठीक है, because there is an absence, still the peristaltic is going on slowly. So first 24 hours is it goes out. Okay, now if it is in the first few weeks of life, in the first few weeks of life, what you will see, there is an gross abdominal distension. The child is taking food, but he is not passing anything. Okay, so there is an chronic constipation. Okay, it has been more than 7 days. He has not passed any stool, and look at his stomach; it is distended. Okay, so gross abdominal distension. Gross abdominal distension. Okay, afterward the child cannot eat. Okay, so there is a failure to thrive. The most common will be this chronic constipation followed with the gross abdominal distension. Okay, now if it is in the grown up child, like the children, the adult, so what is the most common symptoms? If I write it here, okay, I'm just writing here. If it is in the children, okay, now it has not in the first few week of life or in the adult. Okay, there may be everything is okay, but now they suffer from the severe constipation. Severe constipation because of some diseases or anything, that the lower part of the plexus or that the mesenteric plexus or the all plexus get damaged. Okay, so there is a severe constipation. Okay, severe constipation without fecal soiling. Okay, so no stool comes out. So fecal soiling is usually not a feature of this congenital megacolon. So there is severe constipation without fecal soiling. Now how will you diagnose this case? You will do the digital examination. What you will see, the rectum is empty. Stool to hai nahi. Okay, so there is rectum is empty. Okay, on digital examination, or to confirm this, what we will do the rectal section biopsy. It is a gold standard diagnosis to know whether the mesenteric plexus is absent or not. Okay, so what is the gold standard diagnosis for congenital megacolon? It is rectal biopsy or the rectal section biopsy, that is a submucous plexus, a part of the submucosa with along with the plexus. It should be taken out and to see whether this mesenteric plexus contains any whether the mesenteric plexus is absent or not. Okay, so this is the most gold standard diagnosis for the congenital megacolon. Other is, you will see the radiology, you will see a lots of stool is present in the ascending colon, not in the rectum. Okay, so lots of stool is present in the radiology. Okay, there is some abnormal contraction. Okay, and another one is your anorectal manometry. Okay, it is basically for the screening test. So what is the function of the rectum? To know the function of the rectum, whether the rectum is working properly or not, for that we have to do the anorectal manometry. Okay, so in the question, if they ask you what is the gold standard diagnosis for the congenital megacolon, your answer will be rectal section biopsy. Okay, another is your x-ray. You will see a lot of the stone. Another one is an anorectal manometry. It will show you the how is the peristaltic movement of the rectum. So it is useful as a screening test, not as a diagnostic test. Okay, so this is all about your congenital megacolon. So just remember this. I'm just made one mnemonic for that. Let me show you this one. Okay. So write down the mnemonic for this congenital megacolon. CAR SMS. Okay. CAR SMS. So CAR for the, it is most commonly the congenital. Mostly the congenital. What is here? There is an aganglionic section. Okay, no ganglion is present in the lower part of the rectum. Okay, or the absence of the coordinated peristaltic movement. So aganglionic absence of the ganglion cell or the A ganglion or the absence. I'm writing out absence of ganglion cells. In where? In the mesenteric plexus. Okay. Now R for the rectum. The common area will be the rectum. It is the most common location. Okay. And also which type of, because it is gene, the most commonly gene will be the RET gene. Okay. The most common will be the RET gene. Okay. Or if there is a family history of Down syndrome, they have more chances to develop congenital megacolon. Okay. So there is a distension of the stomach. So stomach distension. M for the meconium fail to pass. Meconium fail to pass. Meconium fail to pass. And the most common diagnosis will be the suction. Okay. Suction biopsy of the rectum. A part of the, so this is called rectal suction biopsy. A part of the rectum where consists of submucosal plexus along with it should be taken out. Okay. So this is known as a suction biopsy. Okay. अगर ऑप्शन में रेक्टल बायोप्सी रहा और रेक्टल सेक्शन बायोप्सी रहा, choose the option that's rectal section biopsy. Okay. So these are the card SMS. C for the congenital, A for the absent ganglion cell or the absent peristaltic movement because of the absence of the ganglion cell in the mesenteric plexus. R for the most common site is the rectum. S for the stomach distension, meconium failed to pass, and suction biopsy of the rectum. Okay, so these are the mnemonic for the Hirschsprung diseases. It is a very rare condition and usually seen in 1 in 5,000 live births. Okay, 1 in 5,000 live birth. ठीक है? Okay, and what is the excellent prognosis? Is excellent. Okay, what is the prognosis? The prognosis is excellent after the surgery. So I'm just writing it here. The prognosis is excellent. Only the complication can be the constipation. Okay. Now let's go to the next part about the polyp. Okay, what are the polyp? So there are basically two type of the polyp. One is your neoplastic polyp and the other is your non-neoplastic polyp. So these are not cancerous, but they have more chances to develop changes into the carcinoma. Just write it down. Now we will come by one the type of the polyp. Okay. So let's move to the next slide. Now come to the first about the non-neoplastic polyp. So among the non-neoplastic polyp, the hyperplastic polyp is the most common. So non-neoplastic is more common than the neoplastic polyp. This is the one reason. Okay. Another one, in the non-neoplastic polyp, the most common is the hyperplastic polyp. So this can be one of the MCQ questions. Okay, hematomatous polyp divided into two: juvenile polyp or the P-set polyp, inflammatory polyp, and the lymphoid polyp. Okay. Okay, now the hyperplastic polyp, it is the first one. It is the most common type of the non-neoplastic polyp. It should be less than 5 millimeter. It should be raised but not pedunculated. More common in the distal colon, especially in the rectosigmoid region, especially in the rectosigmoid region. Okay. Histological appearance, it looks like a sawtooth appearance on histology. It looks like a sawtooth appearance. Okay, it looks like a sawtooth appearance. Now, hematomatous polyp, it is especially the two type. One is a juvenile polyp and other one is your PZ, that is Peutz-Jeghers syndrome. Okay, so juvenile polyp, it is also known as retention polyp. Previous slide, okay. This is for you, doctor. Your name. चलो ये लिख लो, and then we will move to the hematomatous polyp then. Okay, let me type कर देना in the chat box if you have finished to write it down after.
Ma'am, this is rectosigmoid section, na?
Yes, rectosigmoid region. The most common in the distal colon. In which part of the distal colon? In the rectosigmoid region. Most foundly in the rectosigmoid region. Okay. Yeah. So now move to the next slide. This is about your juvenile polyp. So in the juvenile polyp, it is also called as retention polyp. ठीक है, इसको याद रखना. It should be about 1 to 3 centimeter in diameter. Okay, so very important. 1 to 3 centimeter is diameter. Its location is mostly on the colon and the rectum. Okay, it's mostly on the colon and the rectum. Clinical spontaneous removal with the stool and the bowel. So the typical symptoms of the like your juvenile polyp will be rectal bleeding. So there will be rectal bleeding plus mucosal discharges, like the symptoms of like mucus, along with that of the some type of the bleeding, a dysentery type of or features. So rectal bleeding is there along with the mucus discharges. Okay, along with the mucus discharges plus diarrhea and the abdominal pain. Remember, they do not have any malignant potential, even the hyperplastic polyp also, and this is juvenile polyp also. Okay, and most commonly seen in the children who is less than 5 years of age. Its most common location in the colon and the rectum. So it is most common in the colorectal hematoma. The age should be most commonly in the children who is less than 5 years of the age. The lesions are mostly the single lesions. Multiple lesions होते नहीं है, single lesions होते हैं. Okay, the single lesions. Okay, and the clinical feature will be your retention, that is a rectal bleeding, mucosal discharges with the diarrhea and the abdominal pain. Okay. Okay, now let's move to the next part of this non-neoplastic polyp. So this is known as your Peutz-Jeghers syndrome. It is also a non-cancerous growth of the one type of the non-neoplastic polyp. Here, in some book, it is written as it has increased chance of the GIT cancer. Okay, they are autosomal dominant. There are the multiple hematoma polyp in the GIT region. There is some blackish discoloration, especially in the lips. Okay, so there is but most common they are the non-cancerous. Okay, they are not cancerous, they are non-cancerous. एक आध दो book में लिखा है, but most in the belly it is written as non-cancerous. So it is in benign growth. It has most common symptoms will be the abdominal pain. There is an internal bleeding and the dark brown or the blue colored spots in the lips, in the mouth, around the eyes, especially in the mucocutaneous region. This is known as your hypermelanotic macule. Okay, so hypermelanotic macule. This is present in the lips, in the buccal mucosa, in the perioral region, anywhere. Okay, so it can be present in the lips, Okay, it is present in the buccal mucosa, also in the perioral region. Okay, this is around the mouth, eyes, even around the nostrils. Okay, so they are the pigmented and they do not have any malignant potential. Remember, PZ syndrome, they are most commonly found in the jejunum. Okay, in the jejunum, then the colon, and then the stomach. So there may be a family history of the same type of the polyp in this type of the cases. So any number of the polyp, but if there is a family history of non-neoplastic polyp, then they have more chances to develop that PZ syndrome. And this type of the polypus usually develop by the age of 20. Okay. So this type of the polyp is usually developed by the age of 20, and there will be a black discoloration in the mouth. There is a various multiple hematoma. They are the autosomal dominant and they are the non-cancerous in nature. Okay. Okay. So, but it is written also that maybe they do not cause us cancer in the GIT, but it has extra intestinal feature also. They have chance to develop in the cancer in the other part of the body. I don't know how it is possible, but yes, it is written that it has extra intestinal increased risk of the extra intestinal cancer of the pancreas, thyroid, and the breast. Okay. So this is all about your PZ syndrome. Okay. Now, adenomatous polyp. Hmm. Now, the inflammatory polyp, they are usually seen is most commonly in those cases, in those patients who are suffering from the ulcerative colitis. The person who is suffering from this ulcerative colitis, they have most chance to develop inflammatory polyps, but also those are suffering from the Crohn's disease. Okay, they're suffering from the Crohn's disease. They have also chance of developing your inflammatory polyp. Inflammatory polyp are no malignant potential. Okay, they have no malignant potential. Okay, but if it is in Crohn's disease, then they have chance to develop because Crohn's disease is pre-malignant in nature. Okay, now come to the adenomatous polyp. Okay, so this is all about your inflammatory polyp. Now come to the adenomatous polyp. So probability of the development, malignancy depends upon its appearance of the lesions. If it is sessile, it has increased risk. Pedunculated has risk is less. In histology, if it is like Villiers, it has higher risk. Okay, whereas the tubular, it is most common, and the size is more the larger the size, increase the risk of this carcinoma. Okay, so risk of malignancy is more in cases where the size is increased. In histology, the highest will be your Villiers type of the adenomatous polyp, and in appearance, the sessile has an increased risk. Okay, so most common neoplastic polyp in adenomatous, which is in all these cases, for example, the neoplastic polyp, this adenomatous polyp is divided into basically tubercular, tubulus, and the Villiers. Okay, and among this, the most common will be the tubular, and the highest risk will be the Villiers. Okay, so इतना ही याद रखना, polyp of the intestine.
मैम पॉलिप तो नॉन मतलब कैंसरस नहीं होता है फिर
नहीं नहीं
ये।
होता है ना, एक है नॉन न्यूप्लास्टिक, एक है न्यूप्लास्टिक है. आई हैव डिवाइडेड दिस ना. द न्यूप्लास्टिक polyp is known as adenomatous polyp, which is divided into three types, and the non-neoplastic is again divided into the three types.
मतलब क्रोन डिजीज में रहेगा तो इसको मैलिग्नेंट पॉलिप उधर
हाँ,
आएगा, और
अल्सरेटिव
इन्फ्लेमेटरी।
नहीं, अभी मैं बोलती हूँ, ठीक है।
हाँ।
एंड पॉलिप, if there is a 100 amount of the polyp, we will come to the later part, adenomatous polyp में if there is a family, if you see the more the number of the polyp 100 से ज्यादा है, that is a familial FAP and they have malignant potential. जरूरी नहीं है कि पॉलिप इज योर हर समय मैलिग्नेंट ही हो। दैट इज वाई डिवाइडेड इनटू टू टाइप, है ना। एक है नॉन न्यूप्लास्टिक, मीन्स जिसकी मैलिग्नेंसी पोटेंशियल है नहीं। न्यूप्लास्टिक मीन्स, न्यू मीन्स जिसमें न्यूप्लास्टिक पॉलिप मीन्स विच हैज मैलिग्नेंट पोटेंशियल। सो ये जो क्राइटेरिया है ना एडिनोमेटस पॉलिप, दिस थ्री हैव, दे हैव चांसेस टू डेवलप मैलिग्नेंसी, but this type of the polyp do not have any chance to develop the malignancy. Inflammatory polyp, it is most commonly seen in ulcerative colitis, okay, but it is also seen in the Crohn's diseases, but rare, ठीक है। बट इफ यू इन द लेटर पार्ट व्हाट यू विल सी, अल्सरेटिव कोलाइटिस की मैलिग्नेंट पोटेंशियल कम है, बट क्रॉन्स डिजीज दे कैन चांस, दे इनकी मैलिग्नेंसी रिस्क ज्यादा है, ठीक है। समझ में आया?
मतलब मैम इन्फ्लेमेटरी पॉलिप भी मैलिग्नेंसी में टर्न हो सकता है?
इन्फ्लेमेटरी पॉलिप टर्न हो सकता है इफ द पर्सन इज सफरिंग फ्रॉम द क्रॉन्स डिजीज, बिकॉज क्रॉन्स डिजीज इज एन मैलिग्नेंट नेचर। हो सकता है वो पॉलिप में ट्रांसफर, बट अगर देखो अल्सरेशन हुआ तो अल्सरेशन इज ऑल्सो रिजल्टिंग इन टू द स्ट्रक्चर फॉर्मेशन विच कैन रिजल्ट इन टू द मैलिग्नेंसी। Okay, so they can, if the person is suffering from the Crohn's disease, not the ulcerative colitis. Ulcerative colitis में chances नहीं है पॉलिप को मैलिग्नेंट में ट्रांसफर होने के, ठीक है।
हाँ मैम, समझ गया।
Basically, or what is written in the book, but when you see in the clinical examination, it is completely very different, like patient to patient. Okay, so it is only for your MCQ. अभी देखो, दिस इज योर familial adenomatous polyp with where there is a more than 100 adenomatous polyp, okay, and these are basically cancerous in nature. The familial adenomatous polyp are those polyp, they have autosomal dominant, it has more than 100 adenomatous polyp, there is a formation of the crypt formation location in the APC gene, in the long arm of the gene, okay, diagnosis by the APC gene testing, and they have a chance to become malignant, okay. So this is about your type of the polyp. So these are some extra intestinal feature of the familial adenomatous polyp. One is if there is a development of the tumor in the mandible and the skull, which is known as osteoma, desmoid tumor, thyroid papillary tumor, medulloblastoma, okay. Benign dental abnormalities, and congenital hypertrophy of retinal epithelium. CHREP means your congenital. These are the extra intestinal feature of the familial adenomatous polyp. Congenital hypertrophy of the retinal epithelium. Okay. Hmm. Hmm. Now let's move to the another, that is about your Gardner syndrome. It consists of familial adenomatous polyp. The mnemonic will be the forest. O for the osseous or the soft tissue tumor. RE for the retinal epithelium hypertrophy. Supranumerary teeth. So these are the syndrome. They can ask you what are the Gardner syndrome consist of, and then they will give you the four options. So ये याद रखना, garden in the forest है, तो forest is your mnemonic. Garden means for the Gardner syndrome, garden in the forest. F for the familial adenomatous polyp, soft U for the osseous tumor, RE for the retinal epithelium hypertrophy, ST for the supernumerary truth. Okay. So this is about your Gardner syndrome. इसका सिर्फ इतना याद रखने से ही होगा. Okay, they can ask you what are the features come among the Gardner syndrome, and then they will give you the four options. Similarly, the turcut means your turban. Okay, turcut means your turban. ठीक है, जो कहाँ पर पहनते हैं, हेड में पहनते हैं, ठीक है। So most common in the turcut syndrome you will find the medulloblastoma. तो पॉलिप के साथ that person will suffering from medulloblastoma. then congenital hypertrophy of the retinal pigment epithelium, and the glioblastoma. Okay, so most commonly most common brain tumor will be the medulloblastoma and the glioblastoma in the Tucker syndrome. Okay, so this is इतना याद रखने से होगा, और कुछ याद रखने की जरूरत नहीं है. That's it. Okay. Now come to the colon's cancer. Okay. So it is again divided into the right and the left. Okay. So this is your splenic flexure. Okay. And remember, in carcinoma of the colon, the most common metastasis will be the liver and then the lungs. Okay. And in the carcinoma of the colon, the most common symptoms will be abdominal pain. This is the most common symptom of the carcinoma of the colon, is abdominal pain. Along with this, obviously, there is some change of the bowel habit, melena, weight loss, okay, weakness, melena, weakness is there, weight loss is there. So these are the other some common symptoms, but the most common symptom in carcinoma of the colon is abdominal pain. Okay, now carcinoma of the colon is again divided into the two type. One is in the right side, they have some another growth, and other is in the left side. Okay, so just write it down here. The carcinoma of colon, the most examination note, most commonly of age is more than 50 years. Sex, most commonly in the male. Right and left के बारे में बाद में आती हूँ. The most common site will be the rectosigmoid region is the most common. Okay, so basically rectal cancer is more common in all part of the, like जितने सारे intestinal colon में है, rectosigmoid is more common worldwide. And in right and the left colon, the right colon cancer is on the right side. Okay, so among the right and the left, the right is more common, but all over the worldwide, the rectosigmoid region, the cancer on the rectum is more common. Okay. Now come to the right side, that is in the ascending colon. Okay. Here, the most type of the growth, what you will see, a cauliflower type of the growth. So in the right side, the right colon, in the right colon, in right carcinoma of the colon, the growth will be a cauliflower type of the growth or the fungus type of the growth. And its a common feature will be your occult bleeding, or there is melena, abdominal pain. Okay, obviously if there isn't bleeding, internal bleeding, so there will be an iron deficiency, anemia, and thus some mass is felt in the right iliac fossa. Okay, some mass is felt in the right iliac fossa. So most common symptoms अगर पूछा जाए in the right colon carcinoma, your answer will be melena, that is internal bleeding. Then melena, iron deficiency, which resulting into the anemia, iron deficiency anemia, and some mass in the right iliac fossa. And the type of the growth in the right carcinoma of the colon is a cauliflower type of the growth. It has a good prognosis than that of the left colon. Okay. Now in the left colon, the most common symptoms will be your change in the bowel habit. वहां पर क्या था, bleeding, यहाँ पर है change in the bowel habit. Either will be alternate diarrhea and the constipation, or there is an loose stools which contains some undigested food particles. When you read the common symptoms of the symptoms in the abrotandem, okay, you will see that there's a change in the bowel habit, and also there is metastatic lymph nodes enlargement in the abrotandem. Okay, so this is one of the remedies can be used in abdominal cancer if you find other clinical features. Okay, that is metastasis from the piles. It is one of the used medicine for the piles when the piles get operated and the symptoms gains, suppression of the diseases. तो whatever, तो अभी इसमें क्या होगा, लेफ्ट साइडेड में चेंज इन दी बावल हैबिट. यहाँ पर मोस्ट कॉमन क्या है, ऑब्स्ट्रक्शन. वहां पर क्या था, कॉलीफ्लावर टाइप ऑफ ग्रोथ था, फंगी टिप टाइप ऑफ द ग्रोथ है. हियर देयर विल बी अ नैरो ल्यूमन. ओके, सो देयर इज एन constriction, that is annular, or the stenosis, or the constriction. Okay, or the constriction of the lumen. Okay, suppose if it is your descending colon, it get constricted. Okay, it get constricted. So this looks like a upper coalescence on the barium enema. Okay, upper coalescence in the barium enema. Okay, so jitna constriction hoga, okay, suppose the constriction is there and bowel is coming, it is not going, the common will be the constipation. And sometimes if you push anything, if you take anything like that, if anything started to push from that this part, okay, so there will be some undigested food particles come from the lumen, which resulting sometimes in alternate constipation and the diarrhea. So diarrhea to nahi hoga, there is some food particles which comes out, that is alternate bowel habit. Okay, so yeah, ये याद रखना, apple coalescence on the barium enema. यहाँ पर the most common feature of left carcinoma of the colon is your constriction, or there is a constriction or the stenosis, where here is your cauliflower type of the growth. This is very important in दोनों का like differentiation. Okay, very important. This is iron deficiency anemia because of the internal bleeding or the melena, but here the most common will be the change in the bowel habit, and it has a poor prognosis. ठीक है, it has a poor prognosis. Now, what is the gold standard diagnosis for the your what to say about your carcinoma of the colon? The gold standard will be the colonoscopy. Okay, the colonoscopy will be the gold standard diagnosis, and for the staging, that is for the investigation of the choice to know the staging, in which stage the carcinoma of the colon is there. That is a CT scan of the abdomen. Okay. So these are the some of the common symptoms: associated abdominal pain, change in the bowel habit, weakness, and the melena. It is basically situated with the right and the left. अब समझ में आ गया, melena is most in the right, change in the bowel habit is most commonly in the left colon. Okay. Okay. So if
मैम
it is especially in the lower part, in the descending colon, okay, so there is a tenesmus is there, incomplete evacuation, and some bleeding also. Okay. So basically, this is a feature of the left colon. So gold standard will be your colonoscopic with biopsy. Okay, for prognosis and for the follow-up, carcinoembryonic antigen and investigation of the joint. For staging of the carcinoma is your CT scan of the abdomen. Okay, so this is all about your carcinoma of the colon.
मैम
Okay.
कंस्टिपेशन तो समझ आता है, फिर डायरिया भी होगा क्या? मतलब चेंज ऑफ बाउल हैबिट में कंस्टिपेशन
चेंज
तो
ऑफ
समझ आ
बाउल
रहा
हैबिट मीन्स पहले हो सकता है उसको डायरिया था, ठीक है, लूज स्टूल्स होते थे, ठीक है, या पहले उसको कॉन्स्टिपेशन था, देन ही स्टार्टेड टू टेक सम मेडिकेशन फॉर द लूज स्टूल, and because of this body has some reactive power, and then it started with alternate constipation, sometimes diarrhea. इसको पूरा पैथोलॉजी में मत देखो, ठीक है, ओके, इसको sometimes in if you read our mathematica books, you will come to know that actually bowel change in the bowel habit mostly commonly due to if there is some ulceration is there, ठीक है. सो एनी टाइप ऑफ, अभी यहाँ पर राइट कोलोन में क्योंकि वहां पर मोस्ट कॉमनली इंटरनल ब्लीडिंग होता है, सो मोस्ट कॉमन वहां पर आपको ब्लीडिंग दिखेगा, ठीक है, बट यहाँ पर रेक्टम के यहाँ पर है तो मोस्ट कॉमनली वो रेक्टम का एरिया अगर ऑब्स्ट्रक्शन हो गया तो मोस्ट कॉमनली कॉन्स्टिपेशन दिखेगा, ठीक है. नाउ व्हाट यू विल, तो पेशेंट विल ट्राई टू डू समथिंग to relieve that constipation. Okay, so there is some change in the like there is a proper constipation तो होगा नहीं, but there is some not diarrhea also, but loose stool. I'm not saying एकदम पानी की तरह. There is some particles of the food, undigested food particles will be present, which is known as a change in the bowel habit. ठीक है. ऑल्टरनेट डायरिया एंड कॉन्स्टिपेशन का ऐसा मत सोचो कि लूज स्टूल होगा पानी की तरह होगा, ऐसा नहीं. देयर इज सम चेंज इन द बावल हैबिट. ओके, so there is some food particles in the stool along with this constipation. This is known as change in the bowel habit. I am telling you on constipation and diarrhea what alag hai, but most commonly the term you will use is change in the bowel habit. ठीक है. कभी कभी बहुत स्टूल लूज होता है, कभी कभी बहुत, तो आप पूछोगे लूज मतलब एकदम पतला, नो नो मैडम, कुछ पार्टिकल्स आते हैं, थोड़े बहुत आते हैं, थोड़ा थोड़ा म्यूकस भी जाता है उसमें से. सो दैट इज कॉल्ड चेंज इन द बावल हैबिट. ओके, यू गॉट इट?
यस मैम.
कि नहीं, नहीं समझा?
यस मैम, समझ गए.
ओके. So if you see patient now after like अगर आप like after your BHMS when you start to do practice, You will literally see some maybe they are not suffering from carcinoma of the colon. They are not. They are suffering from normal like dysentery and any type of the like IBS symptoms. They also will give you the same symptoms. Okay. Now come to the next part of Crohn's disease and ulcerative colitis. ये बहुत important है. Inflammatory bowel disease. There are two types. इसको याद रखो, which is very important, not only for the surgery but also for your practice of medicines. Okay. Now Crohn's and the ulcerative colitis. If you see this, the diagram, the Crohn's will be start the whole GIT tract, means from the mouth to that of the to that of the rectum. But remember this: in Crohn's disease, rectum is always spared. Okay. Though it starts from any part, the whole GIT tract is affected, but rectum is always spared. The Crohn's can be seen start from the mouth also. Sometimes there will be mouth ulcers. There will be no problem, but there is a recurrent mouth ulcer. ऐसा भी हो सकता है in your cases. Okay, but अभी हम लोग जाएंगे only with the MCQ wise. So distribution in the Crohn's disease, if you see, the whole GIT tract is affected. Okay, and here the rectum is spared. In Crohn's disease, there is a skip listens. So suppose some listens in this part. Okay, some listens in this part. Yeah, in this part. Okay, and the some in this part. Okay, but if you see in the diagram, there is a no listens in the rectum. Okay, so this is known as your skip listens. Okay, ulcerative colitis, especially in the colon only, not in the small intestine, especially in the large colon. Okay, so what you will see continuous. So it start from the rectum. Okay, and it's spreading. So it start from here only. Okay, the rectum. So in Crohn's disease, the rectum is not involved. In ulcerative colitis, it start from the rectum only. Okay. And inflammation is a transmural. It can affect the all the layers of the mucosa layer, muscular layer is all the layers, where the ulcerative colitis is superficial. That is, they do not have chance to become malignant in ulcerative colitis. Okay. Cobblestone appearance is a pathology you will find in the Crohn's disease. Here you will find the script abscess, all these things. Formation of the granuloma is formed in Crohn's disease. No granuloma. Okay. Smoking is a causes worsen the Crohn's disease, ulcerative colitis as a protective. तो ये याद रखो, this one. Plus, one thing you should know, in case of Crohn's disease, the most common symptoms will be your colicky abdominal pain in the abdomen. Colicky abdominal pain. Okay. So here will be the common symptoms will be the colicky abdominal pain. Okay. After this, it is followed with that of the diarrhea, which is less intermittent. Pain होगा, diarrhea हो सकता है, या all the symptoms of the Marcot present in the Crohn's disease. Okay, so diarrhea is also there. Is the next frequent symptom. It is present, but not in every patient. But abdominal pain is common in all the patient who is suffering from the Crohn's diseases. Okay, Crohn's diseases में diarrhea होगा, but the bowel movement is not like that of an ulcerative colitis. Ulcerative colitis में bowel movement बहुत ज़्यादा होगा, like मुझे 10 से 15 बार मुझे दिन में जाना ही पड़ता है. But in Crohn's diseases, it is not. It has a typically fewer bowel movement, and stool rarely contains mucus and pus. Okay, okay, and stool rarely contains blood, mucus, or the pus. Ulcerative colitis is a typical feature of your bloody dysentery. Okay, so here you will see the hair 10 to 15 times the patient has to go to the stool, and the stool contains mucus. Okay, it contains blood. Okay, and long-standing Crohn's disease may resulting into the cancer of the small intestine. Okay, so long-standing of the Crohn's disease, they have a malignant potential if it is your long-standing. And the person who is suffering from the Crohn's disease, they have chance to develop perianal abscess, fistulas, strictures, and this. Okay. Now suppose a person comes to you for the treatment of anal fistula. Okay, and after this he is also suffering from this Crohn's disease. So his fistula will take typically more time than that of the other who has some simple fistula. Okay, there are various type of the fistula, simple fistula. Okay, 3-4 tract है तो complex fistula. If the person is suffering from complex fistula along with the Crohn's disease and then he's come to you for the treatment, they are very much obstinate to get to be cured. Okay, simple fistula somehow ठीक हो जाता है, but other type of the fistula they are very it's not ठीक नहीं हो सकते, उनके recurrence बहुत ज्यादा होते हैं. Okay, so ये याद रखना है when you start to do the practice of anal fistula cases. Okay, maybe in all the cases you will not get success. It's only because of the not for your medicines. It's a system which is present with the body of the particular patient. Okay, so this is all about क्या मैंने बोला that is Crohn's disease में whole GIT tract is affected. Skip listens is a feature of Crohn's disease. Pathology, you will see a cobblestone appearance present. Granuloma is a feature of the Crohn's disease. Here, the ulcerative colitis, crypt abscess. Here, the inflammation will be transmural. Here, the inflammation will be the superficial. In ulcerative colitis, start with the rectum, but in Crohn's, it rectum is spared. ठीक है, तो ये पूरा याद रखना. प्लस क्रॉन्स डिजीज का जो मोस्ट कॉमन क्लिनिकल फीचर होगा, द कॉलिकी एब्डोमिनल पेन इज द फर्स्ट feature. Also, the Crohn's, the whole GIT tract is affected. The person might be suffering from superficial aphthous ulcer. Okay, he's suffering from aphthous ulcer and he's taking vitamin C, vitamin B complex and ठीक हो जाता है, पर फिर वो आता है. It's mostly disease if there is a problem with the GIT tract. Okay. Okay, now come to the ulcerative colitis. It's most commonly the diarrhea, which consists of blood and the mucus. Yes, someone is speaking.
Yes, ma'am. Ma'am, in an ulcerative colitis, if they involve only superficial layer, then why chances of malignancy is increased?
Chances of malignancy, Crohn's disease is more in this. Crohn's disease है more है, not the ulcerative colitis.
मैम लेकिन मतलब बुक में तो मेंशन मतलब किया है अल्सरेटिव कोलाइटिस को.
Ulcerative colitis.
यस मैम, इसमें क्योंकि कॉम्प्लिकेशन में है कि इसमें मतलब मैलिग्नेंसी के चांसेस ज्यादा हैं और क्रॉन्स डिसीज में
कौन
नहीं
से
है.
बुक में लिखा है?
मैम जितनी ये सक्सेस में भी है और अदर बुक में भी. मतलब
सक्सेस मत बोलो मुझे, तुम मुझे कोई बुक्स की बोलो करके, एनी पर्टिकुलर नेम ऑफ द बुक. डोंट गो विद एनी मल्टीपल वो MCQ वाला बुक नहीं. ठीक है, अगर दूसरा कोई बुक है ना, क्योंकि देखो मुझे जितना पता है कि क्रॉन्स डिजीज में दे हैव मैलिग्नेंट पोटेंशियल देन दैट ऑफ द अल्सरेटिव कोलाइटिस है. ओके, ठीक है. इफ यू गेट सपोज तो मुझे देना, अगर कोई भी, देन आई नीड टू चेक देन. ठीक है, then I will have to change my what you say my slide. तो हाँ कि चलो ठीक है, ये पोटेंशियल इसमें भी है सब. ओके, और then remember one thing. Let me see also if I see if malignancy is there or not. Let me see in this book. Rectal cryptaxis. Okay. Who is speaking actually? किसने मुझे बताया कि हाँ ये मैलिग्नेंसी है? डॉक्टर्स.
मैम प्रीति सिंह.
प्रीति जस्ट शेयर. ठीक है, अगर कहीं पर भी लिखा होगा सक्सेस को छोड़ के दूसरा कोई अगर बुक में तुमको मिलता है तो प्लीज शेयर दैट थिंग. ओके.
ओके मैम.
ठीक है, like your textbook, not the that success or MCQ type of the book, the textbook. ठीक है. So in ulcerative colitis, so चलो अभी next movement में जाते हैं. So these are already I've told you, that is your cobblestone appearance. In the Crohn's disease you will see a string sign. तो ये याद रखना सब. ठीक है, what are the sign where you will see the cobblestone appearance. Okay. And so these are some extra intestinal feature of these Crohn's diseases. It forms your uveitis. Okay, and pyoderma gangrenosum. In skin में erythema nodosum, ankylosing spondylitis, especially in the kidney nephrotic syndrome. Okay, in kidney nephrotic syndrome, in the pancreas pancreatitis. pancreatitis. And this is the one of the test for the diagnosis. The diagnosis for the so if they ask you what is the investigation of the choice for the Crohn's diseases, okay, the investigation of the choice for the Crohn's diseases is enterolysis. Okay, so there is some imaging technique where a liquid or dye is used. Okay, so this is enterolysis. It is an investigation for diagnosis for the Crohn's diseases. Okay, and these are the serology test. This is known as ASCA test, that is anti-Saccharomyces cerevisiae antibodies test. It has a specificity for the 92% for the Crohn's diseases. So ये कई बार पूछा गया है कि which antibody test is used for the Crohn's disease. This is very very important, that is ASCA test. Okay, fissure, fistula, perianal abscess, they have more chances to develop in the Crohn's disease, especially in the anorectum. Okay. Okay. Now, so, and these are the some extra intestinal manifestation of the ulcerative colitis. ठीक है, that is arthritis, aphthous stomatitis only 4%, uveitis, erythema nodosum, ankylosing spondylitis, pyoderma gangrenosum, and psoriasis. Okay, so these are some extra intestinal manifestation of the Crohn's diseases. So these are some, just write it down, the mnemonic for the Crohn's disease. इसको आप लिख सकते हो. C for the cobblestone appearance, or the skip listens. Most common ileum is most commonly affected. S for the Saccharomyces cerevisiae antibody is present. T for the transmural involvement. Fibrosis and the fistula are more form compared to that of the ulcerative colitis. Radiological sign will be the string sign of Cantor, or the rectum is usually spared. So this is Crohn's sister. ठीक है, Crohn for the Crohn's diseases, and the mnemonic will be the sister. तो कोई भी आप anything you can use. Okay, this is your Christmas and this is your Crohn's sister. This is a mnemonic for your ulcerative colitis. ठीक है. So, sorry, for the Crohn's diseases. So, in ulcerative colitis, it is, I told you, it is superficial and it affects only the two layers, not the muscularis layer. So, we have, what type of, we have mucosa layer, then the submucosa layer, and then the muscularis layer. So, ulcerative colitis, it usually form ulcers in these two layers only, not the muscularis layer. Okay, remember ulcerative colitis में rectum is a hallmark. It started with the rectum. Okay, I have written it here. Yes, so this is colitis का ulcerative colitis mnemonic. It has continuous involvement. Skip lesson is not seen. Origin start with the rectum. Lead pipe appearance is a feature of the ulcerative colitis. Okay. There is an increased growth of the mucosa, hypertrophy. Only the two layer is affected. ठीक है, याद रखना कौन कौन सा layer? The mucosa layer and the submucosa layer. Okay, this only affected. The muscularis layer is not affected. Okay, so there is a toxic megacolon. यहाँ पर there is an increased chance of the colon cancer. तो ये अभी इसको अभी मत ये करो. I need to check it. Okay, there
मैम
may be something. Yeah, यहाँ पर मैंने लिखा है the increased chance of the colon cancer. Let me see in the other book. In the next class, I will definitely tell you the which has more chances. ठीक है, it is Crohn's disease or the ulcerative colitis. Okay,
मैम
Dr.
आई विल चेक इन मुदित खन्ना.
हाँ,
देन इसमें मेंशन है कि जो अल्सरेटिव कोलाइटिस है इसमें अगर मोर देन 10 ईयर ड्यूरेशन का हो गया देन चांसेस विल बी मोर
अच्छा.
इन
एंड Crohn's disease में क्या लिखा है?
इसमें नहीं है, लेस कॉमन.
अच्छा, ये लेस कॉमन लिखा है.
यस मैम.
लेस कॉमन लिखा है. ठीक है, मुझे एक बार शेयर कर देना. ठीक है, मुझे एक बार शेयर कर देना. ओके.
ओके.
और then in the next थोड़ा ये करके then I will tell you in my next class है, ठीक है? थैंक यू डॉक्टर प्रीति। ओके हाँ, तो अभी चलते हैं नेक्स्ट पार्ट में, ठीक है? नाउ टेल मी समथिंग लाइक some of the MCQs है। Crohn's disease can be seen in jejunum only, colon, terminal ileum, mouth to anus है, क्या है? Anybody? Crohn's diseases can be seen in only in the jejunum, in the terminal ileum, from mouth to anus. Okay, anybody? Sorry. Okay, so the answer is terminal ileum. Anus में नहीं होगा because we know that rectum is spared. Okay, very good. Sorry, yeah, it's okay. Terminal ileum. Now come to the next part. Cobblestone appearance is seen in which diseases? Is ulcerative colitis, in Crohn's diseases, appendicitis, and the carcinoma of the rectum. Very easy. Yes, it is your C for the cobblestone, C for the Crohn's diseases. Okay, 1 minute. Huh? Now, suppose if they ask you the question, what is the earliest changes in the Crohn's diseases? If you ask you, क्या आंसर हो सकता है? What is the earliest changes in the Crohn's diseases? मैंने कहा था Crohn's diseases start from the it can be the whole GIT tract is affected actually. Okay, only the rectum is spared.
Mouth ulcer.
Yes, sir. So it is your mouth ulcer abscess formation. Okay, now come to the next part of the vermiform appendix or the appendicitis. Okay, usually two bacteria is responsible for the appendicitis. एक है Escherichia coli and दूसरा है Bacteroides sigillus. Okay, so among this has more common than that of the E. coli. ठीक है, so this is more common. The most common bacteria in isolated perforated appendicitis will be your Bacteroides fragilis, about 80% of the cases, and बाकी के 77 or 70% of the cases is the E. coli. Okay. Now these are the some anatomical position for the appendix. Okay. So most common will be the retrocecal. उसके बाद pelvic, paracecal, subcecal, pre-ileal, post-ileal. The most common is your retrocecal appendix. ठीक है? So what are the causes for the acute appendicitis? Any type of the lumen obstruction. It can be due to the physiolith, most commonly in the adult. In the children, it is lymphoid hyperplasia. Okay. Some types of the parasites or worms infestation, foreign body, tumor is there, but particularly they are the rare. Okay. Now, what is the classical sign and symptoms of the acute appendicitis? ये याद रखना, there is a periumbilical pain, okay, followed by the which shift to the right iliac fossa, okay, followed by the anorexia and vomiting. So पहले एनोरेक्सिया होगा, फिर नौसिया होगा, उसके बाद पेन होगा, ऐसा नहीं है. It start with the pain and then it is followed with the anorexia, then nausea and the vomiting. So typical presentation will be the periumbilical pain followed by the nausea and the anorexia, nausea and the vomiting. The pain is most commonly located into the right lower quadrant region. Okay, and the pattern will be your migratory pain. That is, यहाँ से शुरू हुआ umbilical pain and they shift to the right iliac fossa. Okay, there may be anorexia and then there is a nausea and vomiting, a bout of vomiting, and afterwards a fever develop. Okay, so there is a tenderness also in the McBurney's point. Tenderness in the McBurney's point. Tenderness in the McBurney's point. Investigation for the choice of acute appendicitis is ultrasonography. Okay, and the gold standard diagnosis will be CE CT scan. Okay, so McBurney's point tenderness, it is one of the common symptoms in acute appendicitis. There are some sign is also present. For example, the Rovsing sign. If I can say Rovsing sign, that is pain in the right lower quadrant during palpitation of the lower left quadrant. Okay, so if you give some pressure in the left lower quadrant, there is a pain in the right iliac fossa. So this is called your Rovsing sign. Okay, and Psoas sign means the pain on the extension of the hip. Okay, if there is a pain on the extension of the hip, especially, then the most commonly it will be a retrocecal appendix. Okay, तो यहाँ पर देखते हैं. For example, Dunphy sign is your cuffing. Okay, cuff may elect pain in the abdominal wall. So this is known as your Dunphy sign. That is pain on cuffing. Okay, now come to the obturator sign. Obturator sign means pain on the internal rotation of the hip. Obturator sign, that is pain on the internal, pain in the, especially right iliac fossa, in the internal rotation of the hip. Usually seen in the pelvic appendix. Pelvic appendix. Okay, so a sign, that is pain on the passive hyperextension of the hip. It's suggestive of a retrocecal appendix. Retrocecal appendix is most common. Okay, so to know whether it is an acute appendicitis or not, there is some score which is known as your Alvarado score, or its other name is Mantral score. ठीक है, ये याद रखना. What is Mantral score is used for, what is Alvarado score is used for. Okay, so there will be for example, migration of the pain 1, anorexia 1. ठीक है, so score भी दिया गया है. Leukocytosis score is 2. Shift, that is rebound pain tenderness in the right lower quadrant is also the 2. Okay, now suppose after like if you're getting the a patient of acute appendicitis, and if the patient is telling I have like pain in the tenderness in my this right lower region, then it mark will be 2. Okay, along with this, what are the pain? No, I have the pain is migrated in the umbilicus, or sometimes it is there in the umbilicus. Now I have seen that pain is migrating towards the right iliac fossa. So the score will be 1. Now suppose on adding all the score, if it is the score is 9, between 9 to 10, then appendicitis is confirmed. Okay, confirm. If it is 7 to 8 in between, it is high likelihood of appendicitis. If it is 5 to 6, maybe. Okay, if it is 5 to 6, maybe or may not be. And if it is 1 to 4, that is, it can be ruled out. It is not a clinical feature of the appendicitis. Okay, so if the patient giving you the symptoms in the range of 5 to 6, for further investigation we will have to do the CT scan to confirm the diagnosis. Okay, agar on clinical examination or clinical exam, if the patient is telling you the score will be you find in between 5 to 6, then you have to go with the CT scan of the abdomen to confirm the diagnosis of the acute appendicitis. Okay, so this is all about your uh, acute appendicitis. Okay, so these are some post-operative complication of acute appendicitis: wound infections, intra-abdominal abscess, paralytic ileus, fecal fistulas, respiratory complications, DVT embolism, intestinal hernia. Okay, so these are some post-operative complications of the appendicitis. Okay,
मैम श्वास
now
साइन अगर प्रेजेंट रहा तो रेट्रोसिकल अपेंडिक्स मोस्ट कॉमन उस श्वास साउंड अगर प्रेजेंट रहा तब या फिर एज जनरल में?
no, what is most commonly seen in the retrocecal appendix है. retrocecal appendix most common है ना.
हाँ
Most in
मतलब
74%
ऑब्टूरेटेड साइन
cases
हुई तो हमें
में, हाँ, it is most pain in the hip extension means it is retrocecal appendix है, found in the retrocecal appendix है.
और मैम ऑब्टूरेटेड साइन में वो एक बार
Okay, कौन सा वाला?
ऑब्टूरेटेड साइन
pelvic
obturator sign, ये वाला. Okay, it is written here. इधर भी आप लिख सकते हो, यहाँ पर सब साइन एक साथ लिखा हुआ है. ठीक है, this is obturator sign.
ओके मैम.
Obturator sign is for the pelvic appendix. चलो अभी कहाँ करते हैं अभी, लेट्स मूव टू दी, हाँ, एक और मुझे बताना था, कहाँ गया, या अबाउट योर appendicitis in pregnancy. ठीक है, so appendicitis in the pregnancy, the perforation is most commonly in the 3rd trimester. ठीक है, इतना सब याद रखना. It is in, if there is an appendicitis during the pregnancy, it is very very rare. It is seen is only 1 in 2000 pregnancy, not in, okay, 1 in 2000 pregnancy, and perforation is more common in the 3rd trimester. Okay, perforation is more common in the 3rd trimester, and diagnosis by the ultrasonography. Okay, the look to know and to for the location of the inflamed appendix. And sometimes if the pregnant woman because of the fetus, there might be change of the location of the pain. Okay, the location of the tenderness changes with varies with the gestational period. Okay, so for that reason the ultrasonography is useful for the diagnosis to know the inflamed appendix. And the most common complication which you will the perforation is more common seen in the 3rd trimester. Okay, so इतना याद रखना. तो 3rd trimester में perforation of the appendix is common in appendicitis during the pregnancy. Okay. Okay, now come to the rectum and the anal canal. Okay, so these are the basically the 3, 7 and 11 o'clock is the common piles. Okay, the common location of the hemorrhoids. Okay, these are the common location of the hemorrhoids is your 3, 7 and the 11 o'clock. Okay, one is left lateral. Okay, left lateral, and 3 is your left lateral, 7 is your right posterior, and the 7 is your right anterior, and the 11 is your right posterior. Okay, so 3 o'clock position, that is your left lateral. उतना याद रखने की जरूरत नहीं है. 3, 7 and 11 o'clock position नहीं याद रखना, मैं सिर्फ लिख रही हूँ. You can write it down also. 7 o'clock is your right anterior, and posterior is your 11 o'clock is the right posterior. Okay. Sorry, yeah, यहाँ पर थोड़ा डायग्राम अलग से दिया है. So remember 3, 7 and 11 o'clock. Okay, so if you see this is your dentate line, इसके ऊपर रहा तो internal piles, everybody knows. इसके नीचे रहा तो external piles. Okay, So suppose this is a dentate line, okay, इसके ऊपर रहा, then most commonly in the internal hemorrhoids. If dentate line के नीचे रहा, then it is external hemorrhoids. Usually internal hemorrhoids, the most common symptom will be painless bleeding, okay. The painless bleeding is the most common symptoms of internal hemorrhoids, whereas in the case of the external hemorrhoid, the most common symptom is the pain, okay. Okay, so 1 minute. So what are the common condition where there is a chance of hemorrhoids will be more? So if there is an obesity, any which increase in the pressure of the abdominal region, in intra-abdominal pressure rises होगा, और the piles hemorrhoids होने के chances ज़्यादा हो जाएंगे, okay. So one is your obesity, okay. Other than this, some of the other factor is also, for example, too much amount of the spicy, all those food, तो वो बाद में आता है. First is your obesity, and if the person is suffer from the severe constipation, and the third is your the pregnancy because of the increase of the intra-abdominal pressure. The bleeding जो होगा, that is a bright red colored bleeding, okay, bright red bleeding. And if the too much constipation is too much, sometimes also there will be a prolapses of this hemorrhoids, okay. So there is a bleeding. Some people will come to live with the mucus discharge along with the prolapses, okay. So whenever all the internal hemorrhoids, now whenever you read the following, like Allosocrotina in the Podophyllum, in the Ignatia, most of you will see that they have this internal feature of this internal hemorrhoids, okay. When they comes out, they look like a bunch of grapes, okay. So this looks like a bunch of grapes. So that is usually feature of Allosocrotina, okay. So ये main common इतना याद रखना, internal hemorrhoids जो होगा, they are proximal to the dentate line, and here bleeding is the most common symptoms, whereas the external hemorrhoids जो है, it is your distal to that of the dentate line. They are very much painful. Bleeding is there but very less. Okay. And here you will see a perianal hematoma. So perianal hematoma is a feature of external hemorrhoids. It is also called as a semi-ripe black currant appearance. Semi-ripe, अगर पूछा जाए तो semi-ripe black currant appearance is seen in the internal hemorrhoids or the external hemorrhoids. Semi-ripe black currant appearance, it is seen in the external hemorrhoids, okay, external hemorrhoids, or it is other name of perianal hematoma, okay. So it is highly painful. Now, this is very painful, and the internal hemorrhoids is painless, okay. So it looks like this, okay. Sometimes the patient will give you the picture. If it looks like this, then it is an external hemorrhoids. And the internal hemorrhoid, there is a complete prolapse. You can easily check it out. आपको फोटो देख के पता चल जाएगा, अगर किसी ने पिक्चर भेजा होगा, जब आप ट्रीटमेंट करोगे, आप जब एग्जामिनेशन करोगे, इट इज वेरी इजी टू फाइंड आउट. इंटरनल हेमोरॉइड्स के 4 ग्रेड्स होते हैं, grade 1, grade 2, grade 3, grade 4. Grade 1 means there is a bleeding but no prolapse. Grade 2 prolapse with reduce spontaneously. The patient will tell you, when I pass the stool, after passing the stool, feeling as if something is coming down, कुछ निकल आता है, then it goes spontaneously. The grade 3, it requires manual reductions. अभी तो मुझे उसको हाथ से घुसाना पड़ता है, और घुसाने के टाइम थोड़ा दर्द होता है. If the patient say like this, that means the patient has also have some external hemorrhoids also, if there is a pain. Now grade 4, there is a prolapse and it cannot be reduced. All 3 can be treated with homeopathy, okay. Even if it is grade 4, ठीक है. ऐसा बोला जाता है कि grade 4 एक बार reduce हो जाता है, तो वो नहीं होता, but I have seen in my life, or I have seen also that grade 4 can also be treated with the right homeopathic medicines also, okay. These are actual surgical cases, but you can treat also, okay. Let's move with some of the MCQ questions. External hemorrhoids are painful because they are supplied by autonomic nerves, pudendal nerve, pelvic splanchnic nerve, and the hypogastric nerves. Okay, these are some anatomical question not related to surgery, but फिर भी अगर बोल सकते तो अच्छा है. What are the external hemorrhoids are painful because they are supplied by anybody? They are supplied by the pudendal nerve. Okay, they are supplied by pudendal nerve. Good. Okay, now move to the next part. Painless fresh bleeding per rectum is most commonly due to internal, external hemorrhoids. It is internal hemorrhoids. बाकी जितना है सब पेनफुल होता है. Perineal abscess is another thing. Anal fissure is also there is in bleeding, but bleeding is sticking with that of the stool. External hemorrhoids में bleeding होता है, but comparatively less there is an hematoma formations. Okay, in the picture that I will show you. Thrombus external hemorrhoid present in painless mass, bluish painful swelling, prolapse during defecation, ulcerated lesions. Thrombosed external hemorrhoids present as a painless mass, bluish painful swelling, prolapse during defecations. Yes, very good. It is bluish painful swelling. Okay? So it looks like this bluish painful swelling. Look at this. And typically, just one set tip. This type of this condition, if it is present, you need to ask, how will you get the relief? The patient will tell you two things. If I sit in the hot water, I get too much relief. Only two medicines are there, your arsenicum album and the muriatic acid. Whether it is external, whether it is internal, do not care about this thing. Okay? याद रखना, ठीक है? So let's see. Okay, now which hemorrhoid position is most commonly involved? 3, 7, 11, 12, 4, 8, 6, 12 random position. So this is your record 3, 7, 11 o'clock position. हो गया? Good. So let's move to the next part. अभी इसको करके हम लोग finish कर देंगे, ठीक है? Okay, now introduction. Erectile prolapse, there are two types. One is partial thickness and other is full thickness. ठीक है? Partial thickness prolapse is only the mucosal layer is present. Complete rectal prolapse, all the layers of the rectum through the anal canal. Okay. Internal prolapse, rectum descend towards but does not passes through the anal canal. If feeling something is coming down, bearing down sensation, कौन से ड्रग में है that bearing down sensation is the same thing, whether it is uterine prolapse, whether it is rectal prolapse, anything. The bearing down sensation most commonly seen in the CPR, in lilium tick, and both can be used in female or the male for this type of the reason. Okay, but if a child, basically a children, if it is usually this type of the prolapse usually occur after this. So this is the prolapse of a child. This type of the prolapse is usually occur after the severe diarrhea. ठीक है, पेशेंट जिस तरह के prolapse लेके आएगा, you need to ask the patient, ऐसा कभी हिस्ट्री में हुआ था, any like within 1 month or 2 months, anything, then he will say, yeah, he suffered from the diarrhea, and we give some medicines to control it, and after that he's suffering from this rectal prolapse. Okay, so mucosal prolapse often associated with that of the children, but in case of your adult, if it is an adult, the rectal prolapse is most commonly associated with the hemorrhoids. Okay, associated with the hemorrhoids. Diagnosis by the history, by the physical examination easily, and if it is an internal one, you have to go with the colonoscopy. ठीक है? So in children, the prolapse is usually mucosal, so it can be treated with conservatively. You can give medicines or anything. Okay, but in adult, sometimes it requires a surgical intervention. Okay, so surgical is basically required for the full thickness prolapse. Partial thickness prolapse can be treated with the medications. Okay, now come to the anorectal abscess. Anorectal abscess means a type of the abscess, any type of abscess which is present in the anus area, especially in the anal region. The most common men than that of the female. Okay. Now there are three types here. The perianal abscess is the more common. most common in the perianal abscess. The second is your ischiorectal abscess, and the third one is your intersphincteric abscess. Okay, so there is a formation of the abscess. There is an usually seen in those person who is suffering from some diabetes. They have okay, or some immunocompromised. What are the underlying condition? They are diabetes, immunocompromised, or suffering from Crohn's disease. Some suffering from ulcerative colitis, also the Crohn's disease, and fistula in the ano. Okay, fistula in ano. So most common underlying condition will be the fistula lining in the ano. So whenever there is an abscess, always there is a throbbing type of the pain of the belladonna. Okay. So there is a pain which is your something is throbbing and swelling. Okay, throbbing, swelling type of the pain. If there is too much accumulation of the pus and the patient is not on any medication, there must be some fever, and the affected part is also hot. Okay, so basically this abscess area, it is hot because of the infection is present. There may be fever, and that swelling is sometimes a pain. There is a throbbing pain in the abscess area. Okay, treatment with the medication, they cut and they drain out the pus and then give you antibiotics. If you want to treat with your medications, you have to get that medicines. What the medicine will do, it will create a small hole and all the abscess will come out. I have never seen in the anorectal abscess, but in the breast abscess, I have seen after giving the medicine such as Phytolocca, small hole comes in the breast, and from that small, usually the body itself do the surgery. A small hole came, and from that small hole, all the pus will comes out by itself, and then it heal also. Okay? So obviously we can do in anorectal abscess also, but the difficulty is this, because this area is always wet, so it takes time to heal. Only that the reason. ठीक है? So this is all about your anorectal abscess. इसमें से ये तीनों ही important है. Ischiorectal abscess, perianal abscess, इसमें से तीनों में से कौन सा सबसे common है? That they can ask. Okay. Now come to the anal fistula. So we know what is anal fistula. One is an opening in the exterior, another in the internal part. So basically there are the four type of the fistula in the ano. Okay, type 1 is intersphincteric, transsphincteric, type 3 and the type 4. Among all these three, the intersphincteric fistula is more common. Okay, and then this one, second most common is the transsphincteric fistula. These are also there, but they are less common. So it may fistula mein what happened? There is an abnormal communication, okay, which runs outward from the anorectal lumen to the external opening. ठीक है, suppose यहाँ पर एक external opening है, यहाँ पर एक external opening है. Most if it is this type of opening is there. अगर कोई भी patient तुम्हारे पास आता है, small एक है, usually in these cases the patient will tell you, I have some discharge is always coming out from that area. Some sinus, maybe that is the sinus, but if it is too much old, like 6-7 months ho gaya ya to 1 saal ho gaya, remember that sinus is converted going to be the anal fistula, because he has not treated himself properly. Okay, he took some antibiotic, it goes, but it again recur. Usually seen, what I have seen in this type of cases, the most common cause will be the trauma. ठीक है, ये मैंने खुद देखा है. ठीक है, इसको इसमें रखो, but do this thing. The most common will be the intersphincteric fistula. The tract lies between the internal and the external sphincter. Okay, ये याद है. Okay, what is the tract in between the internal and the external sphincter? Okay, here the no sphincter muscles involvement beyond the intersphincteric spleen. Okay, external opening near the anal verge. This is the most common. And what I seen, the intersphincter fistula, the most common is the trauma. And trauma is what? The patient slips down from the staircase. I have seen 3 to 4 cases have the same similar history, and after 6 to 7 months they develop anal fistula. ठीक है, याद रखना. ठीक है, कॉक्सीडाइनिया हुआ, मेडिसिन नहीं लिया, उसके बाद उसको फिस्टुला डेवलप हो गया. If coccydynia, and if the patient comes to you with the 2 or 3 days after for the back pain, if you take the history, what happened? Oh, कुछ नहीं हुआ था, बस मैं सीढ़ी से फिसल गया था. I slept down from the staircase. Gives hypericum in 10m and the CM potency, this fistula is not going to come back. ठीक है, नहीं होता है. Before अगर फॉर्म भी अगर हो जाता है then you go with a different treatment, but to prevention for the coccidynia, go with this medicine. It is very helpful. I have more than 19% of the cases with hypericum, TEDM and CM, the coccidynia 90% cure rate है इसका, ठीक है, in case of a coccidynia, if the history of a fall from a staircase है, ठीक है, कुछ देखने का नहीं है क्या होता है क्या नहीं है, सीधे hypericum sternum की hypotency देना. You can give 200 or 1 I have never used that thing. I have that 1 potency and it acts like a miracle for me. ठीक है. Now come to the transsphincteric fistula. Okay. This is a tract passes through both the internal and the external sphincter. Okay. May extend it to the ischiorectal fossa. Risk of sphincter damage if surgically cut. ठीक है. ये सब important याद रखना. एनाल फिस्टुला में से उतना ही पूछता है मोस्ट कॉमनली क्या है, बट ऑल्सो यू कैन क्लिक दैट पिक्चर ऑल्सो, ठीक है. सुप्रास्फिंक्टेरिक फिस्टुला, tract goes upward from the intersphincteric spine and arches over the top of the external sphincter. छोड़ दो. And extrasphincter fistula is less common. Okay, so remember this diagram. From among them, this is the most common and it is simple also. Sometimes the patient will give you on MRI, if you go with the MRI of the pelvic region, few patient will develop 2 or 3 type of the fistula. Among them, you will see intersphincter fistula तो होगा ही होगा, and the second is a transsphincter fistula. अभी तक मैंने एक्स्ट्रा स्फिंक्टर और ये नहीं देखा है. मोस्ट कॉमनली आई हैव सीन दिस 2 type of the fistula, and this can be only if you tell the patient to go with the MRI of the pelvic region, then you can hold it up, and you have to tell this to go to the surgeon. They can do the MRI and they can then tell you कि what type of fistula is there. ठीक है. So these are all about your. So what is the clinical? That is some discharge is always coming out, or there is a recurrent boil or recurrent eruptions on the anus region. Okay. So that is what are the, one is CT scan, other is MRI to confirm how many, and other is your fistulography. Fistulography, they can, it is an therapeutic also, they भी लेंगे and then they can cut out the tract also. Okay, the fistulography. So this is all about your and MRI. It is in gold standard diagnosis for the fistula's opening. It is in gold standard. ठीक है. And advantage of the MRI is what? They can also help to demonstrate whether there is a secondary extensions or present or not, which may be missed while you're doing the only the fistulography or doing the surgery. So MRI is the gold standard diagnosis. So anybody who is suffering from fistula, I will tell them, or you can also tell them to first go and do the MRI. Let me check how many fistula is present or not. If more than 2 or 3, tell them it will take time to heal. Okay, if it is extrasphincteric and it is very difficult to treat. Along with if the patient is suffering from any other ulcerative colitis or Crohn's disease, anything. Okay. So this is all about your fissure. Now come to the carcinoma of the rectum. Okay. So carcinoma of the rectum, the most common type will be your adenocarcinoma. Okay. Adenocarcinoma. Okay. Most common type is adenocarcinoma. Usually there is an ulcer present or there is some polypoid growth. Age will be your more than 55 years. The most common feature will be the bleeding is the most common feature, and the other is your sense of incomplete evacuation. Sense of incomplete evacuation. ठीक है. Sense of incomplete evacuation. If it is carcinoma of the rectum, other feature will be your weight loss. Then there is an alteration in the bowel habit. Okay. Along with this, there is some blood and mucus. Okay, so there may be some early morning diarrhea. Okay, and the diarrhea will be a bloody diarrhea. थोड़ा थोड़ा खून मुझे दिखता है. Early morning diarrhea. Okay, and if the sigmoid region is also affected, then the other feature will be your constipation. First, there is an diarrhea, and then there is an increase of constipation if the CA goes into the towards the sigmoid region. Okay. Along with this, also other feature, there is a pain in the back. You will think it is a pain of the sciatica because the pain is radiating just like in the lower limb. So it is, and also involve the sacral plexus. The pain, okay, the pain of the sciatica is also present. How will you the diagnosis? You have to go with the sigmoidoscopy, and the biopsy is the investigation of the choice to diagnose the CA of the rectum. So first we have to do the sigmoidoscopy. If it is rigid, it's not flexible. If we found that it is rigid, then I have to go with the biopsy. Okay. So investigation of the choice for the CA rectum is your biopsy. Okay. And to know the metastasis, we have to go with the CT scan. Okay. We have to go with the CT scan. And to know the MRI is also used for if there is an lymph node staging is there, and also for the overall staging. So all over agar bola jaye that MRI is the best to know the lymph node staging and the staging of the CA rectum. But the investigation of the choice to diagnose the CA rectum is the biopsy. Okay, sigmoidoscopy kiya, that flex that pipe is rigid, it is not going, then we have to do the biopsy. If there is some growth, polypoidal growth, then you have to take the section biopsy, and what we will see, there is some if cancerous cell is present, then there is a carcinoma of the rectum. And most common feature is the bleeding. Okay, the most common feature is your bleeding, and common type is your adenocarcinoma. Okay, so this is all about your rectum and the anal canal. Okay, अभी फटाफट हार्निया करते हैं और फिनिश करते हैं. हार्निया ज्यादा नहीं है, मैंने नोट्स करके रखे हैं. यू कैन टेक इट द नोट एंड दैट मच इज ओनली. ठीक है, ये हैसेलबच ट्राइंगल, दिस इज एन एनाटॉमिकल क्वेश्चन. They can ask you what is the boundary of the Hasselbalch triangle, okay, or the also known as inguinal triangle. I'm not going in the detail. It is an anatomical question. Itna importance hai. The direct inguinal hernia passes through the Hasselbalch ring, and the indirect inguinal hernia, it is passes through the lateral to the inferior epigastric vessels. Okay, so there are two type of hernia. There are another type also, but mostly this is direct and the indirect. Whatever the type of the hernia, either they can pass through the Hasselbalch ring, and if it is indirect one, it can passes to the lateral to the inferior epigastric arteries. Okay, so these are the direct inguinal hernia and then the inguinal hernia. Now there are very type of this hernia. Okay, so okay, now these are the boundaries of the superficial inguinal rings. You can get it from the your anatomy. Okay, pehle main thoda ye sometimes they can ask what are the structure passing through the your external inguinal ring. Okay, so these are the structures: spermatic cord, round ligament of the uterus, ilioinguinal nerve. Okay, now what are the clinical or the risk factor for the hernia? So if there is an increased intra-abdominal pressure such as COPD, constipation, urinary obstructions, pregnancy, ascites, heavy weight lifting, any weakness due to the aging, poor nutrition, previous abdominal surgery, collagen disorders, congenital factors such as patent processus vaginalis, prematurity in infant, some lifestyle factors, smoking, obesity, it weakens the collagen, and some other factors. Okay. So these are the some risk factor for the hernia. Okay. So 8F, you can know the mnemonic for the fat, fluid, fragile, collagen disorder, family history. Certain hernia is common in the female, such as femoral hernia, old age, after 50, fetus, and the force, that is heavy lifting, straining, and the chronic cough, so 8F. Okay. Now this is important. What is the most common type of the hernia in the male? Your answer will be indirect inguinal hernia. Yeah. What is femoral hernia is most commonly in the female. If they ask you what is the most common type of the hernia in female, your answer will be indirect inguinal hernia. Whether it is most common type of the hernia is indirect inguinal hernia. Most common type of the hernia is male and female, indirect inguinal hernia. Female hernia is most commonly seen in the female only. Okay? Direct inguinal hernia more commonly in the elderly. Okay? Okay. Now so what do we know that what is hernia? Because it is a protrusion of the viscus or a part of the viscus through the wall. Okay. So there are basically indirect and direct also, but others are also is there. For example, uncomplicated hernia. So in the uncomplicated hernia, which is reducible, when you tell the patient to lie down, it gets reduces by itself. That uncompleted hernia may be indirect also, direct also. Okay. So uncompleted hernia is reducible and cuff impulse is positive. Cuff impulse is positive. But if it is your obstructed hernia, then it is irreducible and the cuff impulse is negative. Okay. If it is strangulated also, then also it is irreducible and it is also irreducible and there is a compromised blood supply. Okay. Here in obstructed hernia, blood supply is intact, but in strangulated hernia, blood supply is compromised. So they have more chance to develop a gangrene. Okay. Okay, so most patent processes vaginally, it is the most common type of the hernia in the children and the young adult. Now, okay, now what do you mean by the indirect inguinal hernia? A hernia where the abdominal content protrudes through the deep inguinal ring and may travel to the inguinal canal into the scrotum and the labia. Okay. What is the most important cause for the indirect inguinal hernia? It is a patent process vaginalis, most commonly seen in the children and the young adult. Okay. The swelling is clinical feature. Swelling in the inguinal region increases on cuffing, can descend into the scrotum. So these are non-obstructed hernia. Okay. That is uncomplicated hernia. Cuff impulse is present if infant crying increases with the swelling. Okay, so these are the some MCQ point. Most common hernia overall, indirect inguinal hernia. Most common in the male, indirect. Most common hernia in the female, indirect. Most common in the right side. Most common in which side? Right side. Okay. Neck of the site lie and above to the pubic tubercle. Complications, irreducible obstructions, strangulation. It all have strangulation have chance to develop gangrene. Okay. So these are the some of the difference of the indirect and the direct inguinal hernia. Okay. So indirect, it is lateral to the inferior epigastric arteries, direct medial to the inferior epigastric arteries. Origin indirect is mostly congenital, direct is acquired. Age, especially in the young, direct is elderly. Pathway through the deep ring, and this is through the Hasselbeck triangle. Scrotal extension is common, indirect scrotal extension is rare. Okay. So this you should know what is the difference between the direct and the indirect hernia. ये सब इतना याद रखो. उसके बाद कुछ स्पेशल टाइप के हार्निया. फॉर एग्जांपल गिब्बन हार्निया, inguinal hernia plus hydrocele is known as Gibbon's hernia. What do you mean by the pantaloon hernia? Direct and the inguinal hernia, direct and the indirect inguinal hernia on the same side. It is known as your pantaloon hernia. Okay. Femoral hernia, occurs when abdominal content protrude through the femoral canal, which is below the inguinal ligament. Femoral hernia is most commonly seen in the female. Okay, it is most commonly seen in the female. And sometimes the femoral hernia can develop into the Richter's hernia. So this is important. What is the boundary of the femoral canal? This is anatomical question. Okay, anatomical, they can ask you the femoral canal ka boundary. Okay, and what are the content? Okay, so remember this one, or you can, जब anatomy पढ़ोगे तो उसमें आपको दिखेगा. ठीक है, features most commonly in the female, lump appears below and lateral to the pubic tubercle. Okay, and they often small but dangerous because femoral hernia has a chance to become strangulated. Okay, so femoral hernia has a chance to become strangulated. So hi.